Well, thank you, Brian, for the introduction, and I'm going to thank you all for being here. This is a sold-out conference. This is probably our first sold-out conference in the 35 years of the Addiction Division's history. I'm, tremendously proud to have been on the executive committee of this division since its inception. And I also think Arnold Washington may be in the audience. Is Arnold here? Or maybe he hasn't shown up yet. Arnold was the psychologist that gave me my first job working in the field of addictions. And Arnold was the person who spearheaded the birth of this division. Some of us in this division have been, kind of at the forefront of advancing harm reduction therapy. Some of the folks on this executive committee were the pioneers, some of the pioneers in that paper that you just heard described. So, it's been an incredible journey. I know that there are many other people in this room who have been working at the forefront of the harm reduction movement for 30 or 40 years, and we've come such a long way from the time when I was first introduced to harm reduction in 1994 formally, although I was one of those people that was practicing harm reduction therapy before I knew what it was called, like many of the people in this room. It was a dirty word at that point to many people. If you don't get people to stop using, you must be enabling them. And that's an artifact of the disease model, which over these 30, 40 years, there's been a scientific revolution that many of us have been at the forefront of. And in the last several years, there's been an incredible sea change in which people at every level of government and civil society have been shaken out of these old, tired, failed ideas and practices and have been open to what works, what's new, what's cutting edge, and that's where harm reduction psychotherapy fits in. So I was tasked by my executive committee with a topic, and it's a huge, huge topic. So what you'll hear in the next 50 minutes is a number of things that I've come to believe, practices and ideas that I've found very useful relating to this topic. When we shift from an abstinence-only disease model approach in which success is defined as abstinence, it's a binary way of understanding addictive process or problematic drug use, to a harm reduction approach in which we see these issues as falling on a spectrum of severity. We now shift from abstinence or active drug use to a focus on risk, harm and risk. So harm reduction really puts issues around managing risk at the forefront of the work that we're doing. So I thought that the way I understood the task was for us to think together about how do we help people who want our help? Because lots of folks who are struggling with risky and addictive behavior don't want our help. So we're really talking about that group of people who want our support in whatever ways we can provide that. And how do we support them in managing risk to reduce harm? How do we think about the risks to the clinician? And this is something that when we open our hearts and we open our doors to folks that are engaging in high-risk behavior, there are very specific challenges, technical, clinical, emotional challenges to the helper. And so I thought we could think about that. And how do we take care of ourselves? And the last piece is how do we tolerate the emotional challenges that come up? And I sort of floated some of these questions to colleagues and friends And one person said they heard the question is, how do we tolerate the person who's engaging in high-risk behavior? And I thought, I need to correct that and be clear. What we're really talking about is, how do we tolerate the feelings that come up in us? And I would suggest that the feelings that come up in us, which we might call in the most general sense, are countertransference. That is, the full range of experience that we have in relation to the people that we're trying to be helpful to, is the major stumbling block to helping. So that, for me, the effectiveness of this work starts with a radical confrontation with the feelings and the issues that come up for us in relation to the folks that we're trying to be helpful to. So I also want to say a few words about the title of this conference. Sorry. Courage. I think that courage and collaboration are two of the main ingredients that are required for effective work. It takes courage to open our hearts to folks that are engaging in terrifying, risky behaviors, who may die between the first meeting and the second meeting, scheduled meeting. It takes courage. So those of us that are working in this field, I want to honor and affirm and acknowledge, have tremendous courage. It takes courage to open our hearts to meet someone radically committed to not foisting our agendas on people, so that we can really create a safe space to listen to them, to kind of face the unknown. That takes courage. It also takes courage to continually be challenging our theories, our techniques, the traditional standard way of working. And that's really what harm reduction therapy was born out of, a confrontation with the limitations of traditional thinking and traditional practice. So those of us that have been in this harm reduction family, this harm reduction movement, have had tremendous courage, and I also am tremendously grateful to this community for that. Now, how do we deal with the terror that we can sometimes face? It's through collaboration. That's one of the really powerful shifts, paradigm shifts from traditional abstinence-only authoritarian prescriptive treatment, in which we're dictating to patients what they need and what's wrong with them, to a harm reduction therapy, a relationship in which we're trying to level the playing field. And as Debbie Rothschild, who's here, talks about mutuality, really two equal humans coming together to work together in collaboration. And that's one of the core harm reduction shifts. So when I'm terrified about what's happening in my therapy with a patient, the good news is I'm not alone, because I have my partner. Debbie wrote a paper called Partners in Treatment. We're partners with our patients, and we invite them and can turn to them for guidance and support. We also need, very often, a whole team. We need our colleagues, we need our supervisors, we need our friends to go to when we feel overwhelmed and flooded. So it's all about courage and collaboration. So let's move here. So I want to talk a bit about the problem, which is a very upsetting thing to think about. That is the global problem and why we need to do what we're doing. A little bit about the paradigm shift, as I understand it, that we're in. Then I want to talk about, in a bit more depth, what is harm reduction? And why do I think it's essential to the entire continuum of care for people that struggle with risky and addictive behaviors? I want to reflect on risk, and actually one of the things that came up for me as I was thinking about and preparing for this talk is that there's a lot more interesting issues related to risky behavior that I hadn't really fully considered, and I think it's important to focus in on that for a bit. And then shift to thinking about how risky and addictive behavior is meaningful rather than diseased, and then I want to go through some therapeutic considerations. This is the problem. Over the last 20 years, we've lost 1 million people to lethal overdose and drug poisoning. Let's just pause for a moment to reflect on, the catastrophe of that loss and the amount of suffering that has created for individuals and families and communities. The government estimates that we have roughly 20 million Americans struggling from substance use disorder, but they also suggest that we have around 100 million Americans dealing with problematic substance use on a spectrum that doesn't meet substance use disorder criteria. That's 120 million Americans. Only 10% of that 20 million go to treatment, specialty treatment. Only 42% complete. A tiny fraction of that huge group of Americans, or folks living in this country, go to treatment, and a tiny fraction complete it, and I'm not sure how many of them actually benefit from it. I don't know about those statistics. In addition, 100 million Americans are grappling with other risky and addictive behaviors: eating, sex, gambling, shopping. I think Arnold Washington at one point said, asked the question, are we just an addicted nation? So here's another thing for us to consider. Are there the addicts and the rest of us, or are we all on a spectrum struggling with risky and addictive behavior? And there are some folks that struggle more than the rest of us, or than others. Now, what is that dominant paradigm that has been responsible or attempting to address this problem? It's the dominant narrative of addiction as a disease. It's tremendously limited. It's not scientific. And the abstinence-only ethos that has really flowed from that disease model. And I believe that abstinence-only treatment has been a major barrier to care for the majority of these folks. People must be abstinent also before they can go into psychotherapy, and that's been a major stumbling block. So if you can't go to addiction treatment if you're actively using and struggling, and you can't go to therapy, where do you go? Come back when you're ready? That's, I think, largely been responsible for this problem that we're facing. So I don't want to spend too much time on this, but I think it is so important to consider that these dominant negative narratives about people who struggle with problematic and risky behavior have pervaded, they've soaked into the fabric of our culture. And it's so important to consider that because we were all brought up with them, and they live within all of us, consciously and unconsciously. Unconscious bias, what I call social countertransference, right? The idea that people that struggle are diseased, they're sick, or they're bad, or they're criminals, or they're morally weak. We are, pummeled by these images, and have been since we were all very young. And this has contributed to a split between the addiction and mental health systems. And I believe that not only has the dominant treatment based on this not worked, I think that it has actually traumatized many, many, many people who are blamed for not being able to submit to the demands of the treatment system, left feeling worse than they felt when they came in. So here's the paradigm shift. I think we need to shift to what I think of as a rehumanized view of these folks, thinking of these behaviors as meaningful. And trauma is not always, but it's often, if not usually, at the heart of these struggles. Trauma, or however you define it, suffering, tremendous suffering, related to the conditions of our lives and their impact on us. And that addictive process, turning to a substance or an activity to feel better, ultimately becomes deeply ingrained as habit and networked up in the brain through neuroplasticity. There's no one way to treat addiction or trauma. We're learning that. Multiple pathways, infinite pathways, unique pathways to positive change. And so I'm going to suggest that the harm reduction frame is really essential to creating a space to be able to address these struggles. So, I wish I had another table here for my... I want to very quickly go through 3 vignettes. I'm going to read this from a 2019 paper that I wrote in the Psychotherapy Networker called The Challenge of Harm Reduction, because they just capture some lovely humans that I think really epitomize most of the folks in one way or another that come to us asking for help. In his first session, Peter, a successful lawyer, told me that he'd been smoking crystal meth for the past 2 years. I know it's dangerous, he said, but it's like I'm having a love affair with meth. I'm nowhere near ready to let it go. Indeed, his drug use was connected to sex. Every few weeks, he'd go on multiple day binges, drifting in and out of people's apartments or hotel rooms, smoking meth and having sex with men. Some he knew, some were strangers. He looked almost blissful as he described the sex scenes that lasted for hours. But in the last few months, he said, it's gotten a little rough. He said, taking a breath, I started slamming, that is, injecting. And wouldn't you know it? So he pulled up his sleeve. The first session, he pulled up his sleeve to reveal a red, swollen arm marked with scabs, scars, infected puncture wounds. The damage was so alarming, I'm sure that I gasped. Another client, Sarah, drank alcohol and smoked weed every night to the point of blacking out. With no memory of how she'd gotten to bed, she'd wake up groggy with a splitting headache, take an aspirin, drink a cup of coffee, drive to work. In her view, she drank and smoked to relax, but occasionally her hangovers were so severe that they could trigger a grand mal seizure that could kill her. Her doctor had been banging away at her for 7 years to get her to go to AA, which she refused. Finally, he referred her to me. Drew was a 20-year-old man who had taken a year off from college to recover from a life-threatening staph infection. During that time, his drug use had gone from an occasional beer or joint to nearly daily use of weed, alcohol, Xanax, heroin, pharmaceutical opiates, and cocaine. He prided himself on being a well-educated drug addict. I should say. He called himself an addict, but he also called himself the wizard because he was on online chat rooms sort of giving people advice about their drug use. He loved getting high, but he wanted to fine-tune his drug use now that he was back in school. During a phone session, I became alarmed at how intoxicated he was. He reassured me that he was just a little high, but you know, opioids and beer can be a lethal combination. I told him, I need to call you back in 15 minutes, and if you don't pick up, I'm going to call, the National Guard, the RA, his parents, and whatever. I called back, and he didn't pick up, and I called everybody. The RAs found him passed out underneath his bed. I don't know if he had overdosed or just fallen asleep, but is there a breaking point? Ultimately, there's a limit to what we can do, as we heard in the last presentation. So all of these people would probably have been turned away by most psychotherapists if they went for help. They would have been referred to drug treatment, which they all would have refused, and therefore they would have been blamed and told that they weren't ready for care. All of these patients were motivated for therapy. They did incredibly well, but they raised tremendous challenges for me because I had to live with the terror, the uncertainty, all sorts of complicated feelings, wondering if I knew what I was doing, if I was doing the right thing, was I enabling them? When we get real scared, I think we fall back into old thinking. And what I so I'm going to share a little bit about how I, came to learn how to work with folks like this and kind of hang in. Ultimately, they were tremendously successful. So the realities of those folks, I think, really characterize what I think are characteristic of most people that are struggling with risky and addictive behavior, particularly at the point that they become concerned about their use. Most of them, like these folks, don't want to stop. Most of them are in what we might think of as pre-action stages of change. They are concerned about their use, but they're not ready to take action. Abstinence may not be or is not realistic for most addictive behaviors. And people may have different goals for different substances or different activities. So they may actually want to stop the one that they identify as problematic, but not stop the other ones. And for many people who are in very, very difficult life circumstances, right, the circumstances themselves may work against being able to really address their substance use. Living without a home, living without a job, living during the pandemic. I mean, the conditions of our lives may overwhelm us to the point where just surviving becomes most important. So we need strategies that engage people in all stages of change around non-abstinence goals. And that's essentially how I think about the clinical rationale for why we need a harm reduction frame. What is harm reduction? This is a slide from our friends at the Harm Reduction Therapy Center. Maurice Bird is the director of training and development there. I recently did a wonderful training, 3-day training with him. So we brought East Coast and West Coast together. There are 4 pillars of the harm reduction movement. Public health, grassroots. The effort is to save lives and to prevent illness. Human rights. One of probably the worst harm associated with drug use is the war on people who use drugs. I think, when you see something, you need to say something. Well, I really believe that we need to step up and think about what stands we take in relation to these social conditions, and also how they enter into the lives of our patients. Housing First supports everyone's right to a roof over their head, and the health and safety that comes with it, and treatment, the goal being to facilitate any positive change. I think this is a bit of a controversy in the harm reduction movement. I believe that the treatment of problematic and addictive behavior should fall under the harm reduction umbrella, because that's one of the harms associated with substance use. And I think that that's been a blind spot amongst some harm reduction communities and even progressive drug policy folks. That is, treatment is over there and harm reduction is over here. The way I see it, harm reduction is an umbrella concept that really bridges the entire community of folks that are struggling with problematic and addictive behaviors. And the beauty of harm reduction is to really engage people wherever they are on that continuum. So these are some of the colorful indications of public health harm reduction. We talk about how do we help people manage risk. Well, we could start with all of these wonderful public health and medical interventions. Honest education about drugs and risky behavior. Medications for opioid use disorder. I have to say that I was trying to figure out where to fit in psychedelics. And I'm not quite sure where to fit it into this presentation, but I've recently had some patients get tremendous benefit from ibogaine, from ketamine. Certainly in the studies at NYU and Johns Hopkins and Columbia, we're seeing incredible positive results around MDMA and psilocybin for substance use disorder. So certainly some of these should be considered as powerful tools and adjuncts to the work that we do. Syringe service providers, Narcan availability, overdose prevention sites. We're proud in New York to say we have the first 2 in the country opened up in Harlem on site. Part of that is the supervised consumption site, and we need to be testing and talking with our patients about testing for drug purity. If you're on the illicit drug market, there is no such thing as a safe drug. If you're not testing your drugs, You're putting yourself at risk to be exposed to fentanyl, now xylazine, and all sorts of stuff that nobody even knows what it is yet. Luckily, drug purity testing is starting to get out there. This is kind of grassroots harm reduction. Now, Dan Bigg, the founder of the Chicago Recovery Alliance, who was the man who gave me my first Narcan, an ancient Narcan kit that I still have. He was really one of the people that spearheaded the Narcan movement, kind of getting Narcan out. And Pat Denning and Jeannie Little have really talked about substance use management. So this is really the nuts and bolts of how people can tweak their relationships, their patterns of use, to identify and then reduce the harms associated. So it's a practical strategy. Things like never use alone, and there's a wonderful website you should know about, neverlosealone.com. Measuring, counting, pacing, charting, hydrate, eat before, safer routes of administration, test your substances, have an exit strategy. Psychoeducation about the drug setting, that effects of drugs and harms of drugs are not just related to the drug, they're related to your mindset, to your expectations, to your emotional state, and to the setting, the context, the people you're with. So these are very practical strategies. Now the question is, and this is a question that I will often find myself asking at harm reduction conferences, how come folks know about these techniques but they don't use them? And that's where I think the complexity, the dynamics, the meaning of people's relationships to these complicated behaviors becomes essential to address. And that's where I see harm reduction psychotherapy having a major role to play in the harm reduction world, adding a therapeutic framework to public health harm reduction, and also bringing a harm reduction framework to the whole range of mental health and substance use treatment. So harm reduction requires a focus on risk management. And what is risk management? We have to identify the harms associated with specific behaviors. We need to assess the likelihood of negative consequences. We need to have tools and strategies like some of the things that I just mentioned. We need to have the motivation. A person needs to be motivated to make use of all of that. And as I was just saying, we have to address the complex reasons that people take risks. Unfortunately, there have been some people who are the most highly educated people in the harm reduction world about overdose who have overdosed and died. Why is that? So that level of complexity is where I think this group, these professionals, this community has an essential role to play in bringing what we know about human complexity and dynamics into the harm reduction world. And here's where I think harm reduction psychotherapy is essential. So this is how I think about the core. I've sort of tried to distill what I think of as the four core harm reduction principles. Alan Marlatt suggested compassionate pragmatism as a philosophy that actually is embodied or lives through harm reduction practice. Compassion is really the impulse to reduce suffering and improve quality of life. The pragmatic part is that we need to constantly be challenging ourselves, to be asking, is it working? Are our policies, our practices, our strategies, our therapeutic technique with this given individual in this moment, is it working? And that's where I think harm reduction practice brings us to the edge, to challenge our ideologies and our presuppositions. I have to say this, Wilfred Bion, psychoanalyst, said, this work requires us to meet people without memory or desire. And of course, people have challenged that that's impossible. But that's an aspiration to try to leave our theory at the door when we meet people so that we can actually be open to who they are. Any positive change, that's the major shift from abstinence only to any positive change. We want to support any positive change without requiring abstinence, or even more radically, without imposing our values, our agendas, our theories on the people that we're trying to be helpful to. And that enables us to truly meet people where they are, who they are, around their motivation, their goals, what brings them. We can then meet them we have to meet them where they are rather than asking them to meet us where we are, so that we can work collaboratively to tailor what we have to offer to who they are, what they need, what they want. And then rather than a kind of high bar, goal of abstinence, let's think about any small incremental change in a positive direction. That's another part of the reframe. And then we're guided by principles of curiosity, empathy, respect, empowerment, and collaboration. Unfortunately, well-meaning as it was, the idea that people who struggle with addictive issues need to accept their powerlessness, that can be interpreted in many different ways. I'm interested in empowering people. I'm interested in supporting people, in supporting them and getting in the driver's seat of their lives, of their relationships to their behaviors, their relationship to risk, harm, and so on. So here's how I think about integrative harm reduction psychotherapy, which is my approach. And I actually use the term integrative for a couple of reasons. One is that I believe that we're all integrating what we learn from one another all the time. I'm integrating what I've learned from my patients, from my colleagues, from my mentors, from my education. And so I want to honor kind of all of these traditions that have contributed to my work, but I think it's really a reflection of our community. And there can be many other techniques and strategies that can be integrated into this work. My particular way of thinking about it is that we need to be thinking about bringing in interventions that are focused on clarifying meaning, social meaning, personal meaning, relational meaning. But also, we need to be integrating cognitive, behavioral, active strategies that support people to change problematic behavior, assess and change to reduce harm, right? So that's been a major split in the field that I think we need to honor both of those traditions and bring them together. And then mindfulness as a capacity, a technique, a strategy for becoming aware and accepting of what's happening in the present moment without judgment, really supports these other activities. So that, for me, has been a very, very important piece that I will touch on. So here are some of my reflections on risk. High-risk behaviors we might think of as those behaviors that have potential harms. But they're here to stay, right? Life is risky. And high-risk behaviors can be both adaptive and maladaptive. So I think as I'm thinking about this, I want us to really challenge the presumption that high-risk behaviors or people who take high-risk behaviors must be crazy or must be sick or, so we can't presume pathology. It's more, our relationships to risk are more complex than that. They can be adaptive and maladaptive. High-risk behaviors drive exploration, innovation, creativity. Somewhere I was reading somebody suggested that high-risk behaviors have been evolutionary adaptive. It was the folks that were really willing to take risks that discovered fire and discovered new lands. Also, two other things that I came upon. The optimism bias. This is the idea that causes us to believe that we are actually less likely than others to experience a negative event. It won't happen to me. Let's consider these when we are talking with people about their relationships to risk. Risk blindness, reward when we're actually getting something good, we stop thinking about the risk. And I can tell you, I don't gamble anymore. I used to gamble at casinos a little bit. I'd, be willing to lose $100. But, I'd start winning, and then I'd start getting crazy. Really. So I'm like playing very, very, carefully, and I start winning a little bit, and suddenly I'm doubling down, and I'm doubling my bets, and then I lose all my money. So, but also we avoid looking at losses. We don't want to look at losses, so we don't want to think about, we're not motivated to think about the downside. And what I've thought about with many of our folks, or many people who have experienced tremendous traumatic experiences related to risky behavior, blackout, winding up at a ditch, getting into a bad car accident. These are traumatic experiences that may be dissociated as a way to cope with the terrible pain and suffering associated with that. And if we're dissociating kind of past negative harms, that could actually leave us more vulnerable to engaging in those behaviors again. So what if we shift to this idea of a meaningful relationship to risk? And I also have been thinking about what we call addiction really as a dilemma. That is, if a part of me is getting something meaningful and important from this activity, and a part of me is suffering as a result of it, could be a very painful and difficult dilemma to figure out how to resolve. So what are some of the potential meanings when we think about the biology of risk? We take a risk and it gets our adrenaline going, but that gets wrapped in meaning. It lands somewhere meaningfully in us. And high-risk behaviors can express multiple meanings simultaneously. They can also be on a spectrum of awareness. I know why I'm doing this, or I'm mystified about why I'm doing this. And it may be the mystified experience is related to trauma and dissociation. That is, there may be motivations, parts of me that are drawn to risk that are out of my awareness. And from this point of view, the behavior may be like a language that we speak through language rather than being able to symbolize, articulate our experience in words. This is a free solo climber. I don't know if you folks have seen any of these films about free solo climbing. These folks go up, hundreds and hundreds of feet on sheer rock faces alone, without ropes, without equipment. And when I see these films, like, think about mirror neurons or something, my legs start shaking. It's hard for me to watch. But he says, for me, climbing solo is the most intense way to face the rock. Evolving on the rock in such a free way is an incredible feeling. It's moving into another reality, in a space between being and not being, in which consciousness is so deep that one believes out of sheer tension to hear the air crackling. That's why climbing free solo has much more introspection than ascension. So what is that? What is that experience? How do we understand it? So these experiences can be sought for fun, pleasure, liberation, self-care, sensation-seeking, something that I've heard about, we've all heard about, but I did a little more study of. It's a personality trait that seems to have a genetic component, such that some people are more drawn to intense sensation, thrill-seeking, risk-taking than others. The low sensation seekers think that the high ones are crazy. Why on earth would they ever do this? The high sensation seekers think that this is what makes life worth living. Risk enhances learning, mastery, growth, competence, self-efficacy. It may be related to values. I see, being an adventurous person, seeking novelty, new experiences is really important to me. It's part of my identity, actually. I'm a nonconformist. This was a recent patient of mine was talking about this piece. Transcendence, spiritual, transcendence, oneness. Is that what that free solo climber was seeking or was achieving in that experience? Therapeutic risk-taking. You know, we actually ask our patients all the time to take some risks. Why don't you challenge those fears? Why don't you actually, in small ways, kind of take a risk to tell your partner how you actually feel, to challenge the pathogenic belief, right? So, and group membership, peer pressure, like that's can be a very intense thing. If I don't take the risk that everyone else takes, you know, I'm a punk, you know, I'm not part of the group. So, but then on the other hand, well, here's another patient. He said, there are 4 things I love more than anything else in life: backcountry skiing, skydiving, having a big pile of cocaine, and some sex workers, and my family. Literally, he said the problem is the first 3 are not compatible with my love for my family. And I said, and the first 3 are potentially lethal activities, and the last one is probably not. So but again, so what is that? Is that sort of, think about the first, you know, slide of kind of positive motivations or reasons, and now we can think about, you know, that these behaviors may be self-medicating, desperation, agony, terror, may be related to trauma, self-regulation difficulties, real difficulties sitting with distress. Shame and guilt could be related to trauma or related to being a person who uses drugs in a stigmatizing culture. There is Lisa Director, one of our former members of the executive committee, has really written beautifully about the relational meaning of problematic, complicated relationships to substances. Think turning to a substance rather than a person. And intense conflicts and splits, right? Splits between the part that wants fun and the part that thinks that having fun is sinful or is shameful. Or so there are these splits that our clients and maybe many of us have all the time. And related to trauma, this urge may be expressing a dissociated part of the self that only lives in that experience and is not integrated into our lives. So to the extent that there are these multiple meanings, we might think about the addictive relationship as expressing something and disguising it. And from that point of view, the urge and the risky behavior may be an entry point for kind of an exploration and rediscovery and reintegration of those parts. And again, a harm reduction frame that really invites people in with these behaviors without judging, with curiosity and so on, may create the frame that makes it possible to do this kind of work. What part of you wants this? You know, if the urge could speak, what would it say? And then I mentioned before, to the extent these behaviors work, they become overlearned habits, deeply ingrained in neural networks. It's sort of another way to think about why they're so difficult to change as opposed to a disease model, which I think is overly limiting and reducing to biology rather than this complexity. So the psychobiosocial framework really says that you know, there are all these vulnerabilities in that top left circle that lend themselves to people turning to a substance or a risky activity and finding it helpful, which is why people then continue to use, in spite of the accumulation of negative consequences. And from this point of view, we can now understand why do people have a meaningful connection to the activity even while their sort of negative consequences and risks accrue. And that's the dilemma that most people are stuck in. And what this complexity model tells us or suggests is that any one of the relevant factors that people are motivated to come in and work on, that's where we have to meet them. Even if they're not willing or interested in even talking about their substance use or the risky behavior. So, how do we do this? It seems to me, and this is one of the most critical parts, that we need to set the stage, putting a focus on therapeutic alliance and creating safety, particularly with people that are engaging in highly stigmatized, criminalized behaviors that have had a history of punishment and presumption at the hands of disease model abstinence-based treatment. So we need to consider, what are the particular therapeutic challenges that come up for folks like that, for us as clinicians to create safety. And that's our challenge. I think that they're inevitably coming in with a negative transference. That is a negative expectation that just as before, we're going to judge them, we're going to make presumptions about them, we're going to start setting up expectations for them. And we need to disarm that from the first meeting, from the first phone call often. Be transparent about being a harm reductionist. I'll say to people, do you know that I'm a harm reduction therapist? Do you know what that means? Do you know that it means that I don't make any presumptions about your use, about who you are as a person who uses drugs or engages in these behaviors? I just met you. What I'm interested in doing is supporting you in developing your healthiest relationship to these activities as you define it. And it's up to you to even talk about it if you wish. So now, how can I be of help? I think it's also important to kind of share with people this multiple meanings model as an alternative to the disease model. Most people who have been in treatment around the treatment merry-go-round or washing machine have been programmed as with the disease model. The permanent chronic progressive disease only arrested by complete and total abstinence. And if you don't accept that, you're in denial. That's what and so many of those folks feel like I'm in denial or I'm a loser or, stick with the winners, I'm a loser. I keep using. We have to provide an alternative formulation that begins to help them see the complexity as an alternative to thinking of this as simply a disease that shuts down. We know that the strength of the alliance is based on an agreement about goals, strategies, and a good bond, a good relationship. I would submit that the harm reduction framework challenges us and reminds us to put that front and center, the agreement. So how do we come into agreement with our patient around what's important to them? And also we have to prove that we're trustworthy. Right? Why should they trust us? We say that addicts lie. Well, why should they trust us when they've had so many bad experiences in the past? So I say it's on us to prove that we're trustworthy. And it may have to come through what Weiss and Sampson call, the transference test. You say you accept me with my drug use. What about if I come in wasted? Are you actually still going to meet me with respect, curiosity, and compassion? And that could be very triggering for us, right? Especially as one of my trainees said when the person got up and threw up on her carpet. That was a major transference test for her. And they cleaned up the carpet together. So here are my engagement skills. Start where the client is means the invitation you heard in the first talk. How can I be helpful to you? Then it's on us to be empathic listeners. Get our agendas out of the way. What's going on with you? Content, feelings, right? Then I want to engage collaborative inquiry. Let's think together. Let's be in collaboration, in alliance around being curious together. Now I can reflect empathically. This is what I think I'm hearing. And then I want to check in with my client. That's the collaborative part. Am I getting it? Am I right? Are we on the same page? When the patient-client says yes, then we're in alliance. And now at least we know what we're both talking about. Now, what is one of the big challenges? And I think I have 10 minutes. In 1910, Freud wrote, "No psychoanalyst goes further than his own complexes and resistances permit. We must consequently require that he or she should begin the activity with a self-analysis and continually carry it deeper." The way that I understand that is that we're going to be triggered by our clients, particularly around risky behaviors, around everything. But that to the extent that we haven't gone there in ourselves, we may not be able to go there with our clients. So that, the confrontation with risky behavior and trauma, if we really believe that the most powerful thing we can offer is an empathic openness and an empathic reflection that we get their experience, we need to have gone into that experience in ourselves. And if we get triggered and have difficulty going there empathically, then we need to go and do some work on ourselves with our therapist, with our supervisor, with our peers. And this is where countertransference management comes in. The idea is to prevent or repair detrimental effects of countertransference. We have to be able to tolerate the feelings. How do we tolerate the feelings? That's a central challenge for us. Mindful self-reflection, insight. Why am I feeling so triggered? Is it about me? Is it about the client? Is it about something we haven't talked about? Is it about my model that I'm thinking suddenly this is an addict that I can't trust and they're, whatever? So this kind of confrontation with our models constantly is what's required. Anxiety management techniques, is it being induced? So is my feeling that I need to rescue and save really a reflection of what the patient is needing from me, at least needing for me to know about and to talk about? Or is it that I'm being challenged in my own lived experience? I'm remembering when I was there or when my loved one was there, and I'm starting to panic. And it's a collaborative process. If I'm freaked out and I don't know the degree of risk with this person, then we need to talk about something. Is that because we haven't talked about it? Is it because the person is unwilling to talk about it? So then I want to turn to my partner, my patient. I'm really scared. I'm really concerned. Can we talk about it? Can we talk about risk? So here's where the therapeutic alliance is key, creating safety to be able to have that conversation. Know your risk tolerance. Some of us can't handle certain levels of risk. That's okay. At my center, there are some folks who are like, whoa, they can handle incredible things, and other people are like, no, please don't refer that person to me. That's fine. Let's know our risk tolerance. Trust the relationship connection. If I feel connected and we're really talking about it, I'm going to feel comfortable, or at least optimistic, and maybe uncomfortable. But know your limitations as a helper. We can't save people. We can maybe support people in empowering them, in developing greater capacities to care for themselves. So I'm going to run through, so you can read my paper, 2010 paper with Scott Kellogg, Integrative Harm Reduction Psychotherapy. We go through, therapeutic tasks, enhancing self-regulation with all these capacities. Urge surfing is a wonderful technique that brings mindfulness and breathing to the urge, that enables people to sit still with the distress of the urge so that you can actually think. And now we can explore what's living in the urge. We can do a cost-benefit analysis. We can think about alternative ways of caring for oneself. We can also do a microanalysis, looking at how it helps, how it hurts. We can do that unwrapping of the urge, looking deeply within. And we can work on inviting the ambivalence into the room and really supporting people in developing more constructive dialogue between the two sides of that ambivalence, which then leads to thinking about kind of new harm reduction goals. What would help the part that wants to use or engage in that behavior in an alternative way that would support the part that wants to change? And now we can do our optimal use plan, do a comprehensive plan, what Debbie Rothschild calls behavioral coaching, to really get into the nitty-gritty of how do you have substances in your life in a way that maximizes the benefit, minimizes the harm. But here's what I know everybody is wondering. I always get this question. Okay, but what about my license? What if something terrible happens? Am I going to get sued? Important questions. I must say, in 40 years of working with these folks, I've never lost a person to overdose. Hey, lucky me. I mean, unfortunately, some of you have. And I don't know if that's a testament to harm reduction therapy. When we actually offer people a healing, supportive, empathic relationship, as opposed to denying it, the risk, I think, goes down. But these are some of the things that I've come to work with, and also checked with some colleagues. Maintain a list of your acute high-risk patients. Review those patients at a weekly team meeting or with your collaborating professionals. You're working with a psychiatrist, you're working with another therapist, whatever. Document all of these discussions. Justify the rationale for your treatment plan. I think if you have a good rationale for why you think that you should keep this patient in treatment, how you're understanding the dynamics, how you're formulating the case, and as Bruce Wampold says, that good formulation then leads to a treatment plan. If you can really document that and really believe in that, and also document that that you believe that this treatment would be more effective than some alternatives, right? And also the risk reduction strategies. Finally, how do we take care of ourselves? Self-care is so important, right? Self-observation, working on monitoring and managing our own stress. In craft, they say the first thing for concerned significant others to focus on is self-care and boundaries. I think that's the case with all of us helpers. Healthy work-life balance. Balanced caseload. How many high-risk people can you take in your caseload? Turn to your supporters. One of the wonderful papers I read about vicarious traumatization was by a group working with very difficult folks. They said half of their staff meetings were devoted to what they called feelings time, processing the feelings, talking about the struggles, and that seems to be just a really, really important thing for us to be able to do in order to manage the challenges. Is there a breaking point? I wish I could read you a wonderful case, but look, we all have our limits. I need to feel confident in this therapy. When something really troubles me, I need to think about, why am I worried? Assessment is objective, subjective. Is there a clear and present danger to the person or to other people in that person's life? And it's not always so clear. If I feel disconnected, I might be more concerned. Waking up in the middle of the night sometimes is like a signal, like, uh-oh, there's something going on I have to really address. And then I might bring it to the patient. Don't coast in the countertransference. Don't say, I'm really worried, but I don't want to upset the patient. Bring it in. Talk about it. See if you can actually come to some greater clarity. And yes, there's a breaking point. We all come to that point with some patients. And I think of three, I'm going to take 30 more seconds, 3 patients where I have come to that point where I basically said, I am so concerned and I don't see this therapy helping you move in a positive direction. It seems like I'm supporting you in getting to the edge of a cliff and holding your hand, and you want me to jump off with you, and I won't do it. If there's not sufficient motivation for change, if the person isn't meaningfully engaged in therapy, if they seem to be dead set on suicide, suicidal substance use, then I need to bring that to the patient, and I don't see it as a viable therapy. In each one of those cases, the therapy ended, and they all actually went on to do incredibly well. In 2 of the cases, the therapy ended. In the other case, the patient pulled himself together. But there is one patient who was one of the most complicated folks. He was sociopathic. He started to steal from us. He was working with 4 people on my team. He was injecting heroin and ripping off his heroin dealers. And we said that we needed him to agree to take Suboxone to reduce the risk and take it under observation. He agreed, and one day he said he refused. And the entire team felt that he was too much at risk of dying, and we said, we cannot continue to treat you. You need to be in a residential program. He panhandled in front of our offices for 2 weeks, and then he came back and said, okay, the guy is now working for the DA's office in a western state, and he's going to law school. So And the folks I checked in with who were working on that team, including me, said it was the power of the therapeutic alliance and the relationships that communicated to him that he was cared for, he was valued, and he was able to then take that as a spur, to do what he needed to do to take care of himself. So, thank you so much.